Welcome to AETCM, the Emergency Medicine Channel. 26-year-old female with no comorbidities presented with vesicular lesions in the body associated with fever and rhinitis for the past 2 days. Initial 10-second assessment, airway is patent with no added sounds, secretions, gurgling of sounds. Breathing wise, saturation is 98% with the respiratory rate of 18 per minute. Bilateral air entry present with no added sounds. Circulation, pulse rate is 84 per minute with S1, S2 present. BP of 110/70. Disability wise, GRBS is 110 per minute, 110 milligram per DL, and exposure temperature is 100 degree Fahrenheit. So in patient, it's a 26-year-old with no comorbidities, given history of high-grade fever with rhinitis for the past 2 days, and the patient noticed vesicular lesions in the abdomen and back today morning. On the day, and presented to ER. Patient also giving history of exposure to chickenpox, as her roommate was having similar complaints 2 days.
She never had vaccination?
Never vaccinated, never had any history of chickenpox prior. So, on local examination, it was a vesicular lesion with an erythematous surface, fluid-filled lesions. Multiple lesions were there in the back end.
Where it started first?
She noticed it first on the abdomen.
Okay. Normally it starts in the abdomen. Severe body pain, abdominal lesions are the first finding. Then it spreads everywhere.
But
whereas in varicella zoster, herpes zoster?
Herpes zoster is dermatomal.
Dermatomal. Mostly it is dermatomal. Very rarely from dermatomal lesion it can spread all over the body. Okay. Like severely immunocompromised patient, multi-dermatomal disease can be there. Okay.
On systemic examination, constitution was an oriented patient with bilateral air entry, no added sounds, and parabdomen soft with no disabilities. So, since with vesicular lesions, fever with rhinitis, our initial probable diagnosis could be a chickenpox or vesicular disease, fever with vesicular lesions. On CBC CRP wise, total counts is 6.2 with an HP of 12, and lymphocyte was predominant.
Okay. Lymphocyte predominance indicates what type of infection?
Viral.
Mostly it is viral infection.
Since chickenpox is a clinical diagnosis with associated typical his exposure history is given, we manage the patient with symptomatic management.
Okay. What symptomatic management?
Patient is having fever and rhinitis, so we can give paracetamol. Paracetamol and antihistamines for rhinitis.
Okay.
Then valcyclovir we started 1 gram. We started, and
1 gram.
1 gram TAD for 5 days. Okay. Since patient presented to ER within 24 hours of this lesions.
Okay.
Then
what is the dose of acyclovir?
Acyclovir 20 milligram per kg, but 4 times a day.
4 times.
Acyclovir also 20 milligram per kg, but 3 times we can give it.
Other one is 5 times a day.
5 times.
But this is 3 times a day. That is the advantage.
Then other lactocalamine lotions and other
what are the complications of chickenpox?
Chickenpox, most common complications in a immunocompetent patient, it is a self-limiting disease. Okay. After 14 days after lesions crush off. But in case of immunocompromised patients or in newborn children, pregnancy, it could cause complications such as pneumonia. In adults, most common is pneumonia.
Chickenpox pneumonia is most common.
Then encephalitis, immunocompromised, there could be hepatitis.
Okay.
Then meningitis can occur, and local skin infections can also occur.
Okay.
Most common organs are invasive streptococcus.
What is aseptic meningitis?
Aseptic meningitis, when we take a tap, like CSF is tapped, which shows no growth or no organisms.
Septic meningitis is patient is having like something like chickenpox or some other lesion, skin lesion, some other infection in the body. Brain has shown some inflammatory reaction to that. Actually, there is no entry of bacteria or virus to the CSF. Okay. That is also called as aseptic meningitis. Most of these type of conditions can have some type of aseptic meningitis. Okay, that doesn't mean that the virus has crossed the blood-brain barrier and produced encephalitis. The direct invasion also possible, but the other one is more common. Then,
other complications include varicella superinfection, dehydration, then encephalitis. Rice syndrome can also occur in children in case of aspiration. If in a viral fever, if aspirin is being taken,
previously we used to give aspirin for all fevers, fever, pain. Aspirin was the drug of choice. That time when we treat chickenpox with aspirin, especially in children, they used to develop hepatitis and hepatic encephalopathy. Nowadays we don't see that.
Then transverse myelitis, vasculitis, hemiplegia, everything can occur. Then other local infections like cellulitis, myositis, necrotizing fasciitis, even toxic shock syndrome can occur in skin infections. Complication wise, even otitis media can also occur.
What is herpes zoster?
Herpes zoster is a reactivation of varicella, which is getting dormant, like latent patient.
Dormant virus from a dermatome. It is in the spinal cord. Dermatome. It is spread only to that dermatome. Okay. Commonly in the chest areas. Okay. Or sometimes it can form the face, fifth cranial. What is Ramsay-Hunt syndrome?
This facial nerve get affected by most probably virus get dominant in genicular nucleus of facial.
Otitis media with facial nerve affected, and the patient can have lesions on the ear, pinna, and hearing loss, all these things. Okay.
Treatment wise, symptomatic management with acyclovir or valcyclovir. In case of complicated, even acyclovir can be given in IV.
IV, what is the dose? IV?
10 mg per kg.
IV TID. Okay.
Vaccinations are varicella vaccinations are available. In case if it is less than 4 years of age, after 1 year we can give vaccination. It is less than 4 years, first dose is only enough. But more than 4 years, 2 doses with a gap of 28 days we can take. In post-exposure vaccination, the most specific varicella zoster virus specifics is Varisic, which can be given within 10 days of exposure. IM dose we can give or IV dose. In case
that
of
is, you are talking about immunoglobulin. Immunoglobulins can be given in pregnancy. Okay, but vaccines post-exposure may not be very useful, but the amount of disease complication can be slightly reduced if you give vaccine after the exposure. And short duration vaccine, like first week you take first 0 and first week you take, you can reduce the possibility of the extensive disease, but it will not prevent the disease. Prevention you have to take much earlier. Okay.
Complication wise, there's a congenital varicella syndrome where to transplacental transmission of varicella virus to mother to child, where baby can have cutaneous scarring in dermatomal pattern, neurological issues like intelligent disabilities, microcephaly, hydrocephaly, ocular problems including optic nerve atrophy, cataract, chorioretinitis, microphthalmitis, then a limb abnormality like hypoplasia, atrophy. It can be either diagnosed by PCR from the amniotic fluid, PCR varicella DNA, or ultrasound showing deformities. For this, we can use immunoglobulin to prevent.
Suppose you have a patient who is exposed to chickenpox, but he is not that rich to take your immunoglobulin. They are very costly. How do you treat him? A person is exposed to chickenpox, he is not vaccinated, he is not rich enough to start your immunoglobulin. That is very costly. So how do you manage that situation?
If the patient is immunocompetent, no other comorbidities.
Suppose you have not taken chickenpox vaccine. She is already having chickenpox. You are going to get, and you don't have money to take your immunoglobulin. So what is the option? Next option?
Assay. Then assay
If the
clove.
patient develops fever, immediately
Then
start
assay
acyclovir.
clove.
Because fever comes first. Fever, next day or next day, you'll develop lesions. So in that case, suppose you develop fever after exposure. So you immediately start acyclovir so that the number of lesions can come down, and the severity of disease can come down, complication can come down, but still you get a chickenpox. There is no prevention. You are getting chickenpox, but the severity is very, very less.
Yes.
Okay, once you get chickenpox, can you get again chickenpox?
No, sir.
It is not possible.
No.
So, if your immunity is good and if you are developing chickenpox, that is something like vaccination, lifelong protection from chickenpox. But if your immunity is very low, you are getting chickenpox. Again, there is a possibility of developing chickenpox, like patients who is on anti-cancer drugs. If they develop chickenpox, their immunity is not good. Their antibodies will not create properly, so they can again get chickenpox. So that is a problem. If you are having good immunity, once you get disease, it's like vaccination. So even if you get disease, if it is a severity is very, very low with the help of the tablet, so wasting money on immunoglobulin may not be like useful in our country. Okay, where we cannot pay the huge amount for immunoglobulin. Okay, so that is an alternative, but not scientifically correct.
So then premature abortions can occur in pregnancy in case of
so
chickenpox.
pregnancy is very, very important. The patient develops chickenpox during pregnancy, there will be a lot of complications. So there you have to definitely give immunoglobulin. So that there is no other option. Or like I told, if the patient is exposed to chickenpox, if you are sure that he is going to get chickenpox, start treating the patient.
Then there's a condition called breakthrough disease where 20% of children after receiving first dose of varicella vaccine can develop infection.
Okay.
Then
so that infection will be minimal. Again, in children, the chickenpox is very, very minimal disease, not like adult. When your age advances, the disease severity is going to increase. Suppose you are getting chickenpox in 60 years or 70 years, the severity will be very, very severe. If you are getting chickenpox at your very younger age, then the severity is very, very less. Whatever it is, now we are giving vaccine for everyone, so that at least in our state it will be prevented.
Immunization is given to every children in less than 5 years in our country, in our state. So transmission is basically through nasopharyngeal secretion or direct contact with the vesicular lesion.
Can varicella zoster spread?
No, sir. Not like a very difference.
Not like you told that it is nasal route. Okay. But that will not happen in varicella zoster. That physical contact will spread the disease.
Then not the varicella zoster, like in case of normal chickenpox, prior to the vesicular lesion also patient will be contagious, but in case of shingles or herpes zoster, after the lesions only patient.
So initial phase patient have rhinorrhea, cough, sneezing, body pain, that will resemble like any other viral disease. That time only the spreading occurs maximum. Whereas in herpes zoster, it is during the lesion, when lesion occurs, when you have a contact with the lesion only, you'll develop the disease.
Patient will be completely disease free, or won't be any transmission, like transmission risk is less when all these lesions become crusted, which will take like 10 to 14 days.
So you'll get a request for giving leave letter for chickenpox. What will you write? How many days you leave?
Till the lesion crust off.
That is very important. Okay. So till the lesions are completely subsiding, you have to advise the patient to take rest. Okay. Otherwise, it can be communicable. Okay.
Yes.
Thank you.
Thanks.